So we'll just wait as our participants start to join, and then we'll get started. So just as a note to all folks who are joining, we will be recording this session just to be used internally. So folks can then go onto our internal link and watch any of our old sessions that we have. So I wanted to just welcome everybody here to another one of our AHRQ Director Series conversations. These, again, the goal of these are really to kind of challenge our thinking at AHRQ and to really bring in some folks who we either haven't heard from before or who are speaking on a particular topic. And we're really excited today to have Emily Holubowich with us, who's a treat for those who don't. Be a great conversation. But before we start off with that, I want to make sure that everyone has their calendar marked. We have two more in this current cycle, and then we'll have an entire new contract at some point. But we have so to mark your calendars, March 17th, 12:30 to 1:30, we'll be having our discussion with Dr. Christine Sinsky with the American Medical Association. And that will be an interview style conversation with Dr. Arlene Bierman, just like this one is with Boyce on particular topic areas that are relevant to their areas of expertise. And so that conversation will address the crisis in clinician well-being and how AHRQ systems, research, practice improvement, and data and analytics can really help working conditions and reduce burnout. So we really hope you'll join us for that conversation. And then we have one more on our list from March 25th from 11 to 12. Which will be a discussion with Arsenio Mataka, who serves as the Senior Advisor for Climate and Health Equity to the Assistant Secretary for Health. So we're really excited about all of our speaker lineups. And as a reminder, we're going to have a discussion with Boyce and Emily, and then questions can go in the chat, and we'll when there's about 20 minutes left, we'll open this up to AHRQ staff, and we really do hope you participate and ask questions. So with that, I'm going to turn it over to Boyce to kick us off.
Great. Thank you, Jamie. Good afternoon, everyone. Really excited today to have Emily Holubowich with us. Some of you may know Emily. If you don't, you should. Emily and I have worked together. I won't even say the number of years, but it'll date us both, so I won't do that. But it has been quite some time. At any rate, Emily got her start as a health analyst. She cut her teeth at the federal government with the GAO, and so she was their health policy shop there. And then she then went over to Academy Health, where some of you may know her from her role at Academy Health, and she directed government relations there. She then moved over to senior VP at the CRD Associates, where she continued her work in public health, advocating for research, including health services research. So we were still very much working closely with Emily. And then she, in her current position, is now Vice President for Federal Advocacy at the American Heart Association. So she certainly has a lot of longevity in public health, and particularly in health services research. So what we're looking to hear from Emily today is about strategies for engaging with policymakers. How can we communicate our message, our research activities to the policymaking community, which at times is really a lay audience. And so I think that Emily will help give us some insights there, and we're really looking forward to hearing from Emily on that. So why don't we get started here? And Emily, we'll dive right in, and then we'll try to focus my questions on helping some folks here at the agency. The focus of your career has been to help organizations like AHRQ educate stakeholders about their work and the value of science in making policy. Why is it an important function for these organizations and their staffs and funded researchers?
Well, it's such a great question. And thank you so much, Boyce, and to the team at AHRQ for inviting me and for the kind introduction. Yes, we have known each other a long time. I will not date us. But if you knew me before I even was doing government relations, and I first came to Academy Health and then started doing government relations work there. And I've always so valued your friendship and our partnership. And for me, I will say, while it is not part of my full-time job now to advocate for AHRQ. The mission of AHRQ and the importance of your work is near and dear to my heart. And so you will always be the little agency that could for me. And I will always be there cheering for you and rooting for you guys on Capitol Hill. And so why is it important function? Well, then maybe I'll just take a step back and it's like, what is it that I do? Like, what is advocacy and what is talking with policymakers? So, really, I think of what I do as very similar to being a door-to-door salesman back in the day. Instead of selling products, I'm selling ideas. I'm selling policy change. A lot of the principles are really the same. You get used to having a lot of doors slammed in your face. You get used to being told no. But really critical to communicating with policymakers on any issue is, and I think critical to sales, is understanding your customer or understanding your audience, what resonates with them, what speaks to them. It includes a lot of listening. If you're doing it well, you should be listening more than you're talking. So you can really understand where people are coming from and frame arguments and frame messages in such a way that will resonate most with them. And so when we talk about AHRQ and the mission of AHRQ and health services research, it is, I'm not gonna lie, it's challenging. I think there is a very well understood base of knowledge on Capitol Hill and among other lawmakers of what is biomedical research. Like, they get that, the search for cures. And so they've been hearing about it for a long time. They see it themselves in receiving care at NIH, National Institutes of Health. They see the money going into their districts and their states and having a real impact in their communities. It's very tangible. They really get it. Where they struggle a little bit is then, so what is health services research, and how does the Agency for Healthcare Research and Quality interact with NIH? Why do we need it? How is it different? How is it unique? And so having all those questions, I think, makes it critically important to be vigilant and proactive in really telling the story of the agency and the value of the work. And working very closely with Academy Health for very, very long time and many years with you boys, and thinking about how best to tell that story and what will really resonate with policymakers. We like to talk about the research continuum, so it doesn't stop at the bench or even the bedside. This is really about understanding how to get the discoveries from NIH to the patients who need them when they need them at a cost that is affordable. I mean, that's really what health services research is about. So part of my role as an advocate for many years has been to just connect the dots for lawmakers. I get that you care about NIH. I get that you care about the search for cures, but how meaningful are those cures if they're not reaching patients? And that's what AHRQ is really about, and the work they're funding is how are we getting those new discoveries to patients in a way that's equitable, affordable, accessible. So hopefully that helped start to answer.
That's wonderful. And actually, thinking about that, Emily, as I said, some people may know you and some may not, and some may not realize how integral the role you played in the past years when AHRQ was under fire, quite frankly, and you helped, as we would say, save the agency. And we probably wouldn't be here today without a lot of Emily's heroic efforts here. And, in doing that, and you and I and others were in the trenches in a lot of this. What would you say during that time, or even at that span of time, would you say was what you learned about communicating health services research? And was there something that really kind of caught on that got policymakers' attention? Like, oh, you know what? This is an agency that we should really maintain important, critical work that they do.
It's so funny, boys. So reflecting on that experience, and so folks know if you hadn't lived through it, I can share. This is actually a very, very funny story. I will never forget this moment. I was moderating a panel about the importance of advocacy for health services research at the Academy Health annual research meeting. And I got a text message from a colleague on Capitol Hill who was a staffer. who had seen the text of the appropriations legislation coming out of the Labor, Health and Human Services subcommittee. And they said, so there's no money for AHRQ. And I texted back, what? And so I'm on the dais and we're about to kick this off. And so I was able to break the news at that meeting in my introductory remarks and introducing my colleagues on the panel to be able to say, so we're talking about the importance of advocacy today. And if you want to know why it's important, let me tell you, I just got a text message. Here's what it said. We had the collective gasp in the audience. Like, wait, what happened? And so what was so interesting to me about that experience, there were a couple things. First and foremost, which I think a lot of people don't realize, is just how powerful congressional staff are. And we'll talk more about kind of when we're talking about communicating with policymakers. I put staff in that category, and they're an important audience. But congressional staff are extremely influential. And if you think about it, for example, if you're a CEO of an organization, you can't possibly know the minutia and the detail of everything that goes on day to day in your business. Your responsibility is hire good people who can manage those things and execute those things and kind of alert you when there's a problem. And that's somewhat how congressional offices work. A member of Congress has too many things happening. They don't actually sit down and write legislative text. That's the responsibility of the staff. And all the information they receive, most of the information they receive is through the filter of staff. So they're very influential. It also demonstrated to me the impact of complacency. So I think for too long, as is typical, with appropriations and federal funding, things tend to run on autopilot. And we take that for granted. And so you just expect that the funding will always be there and the funding will always flow because it always has. And I think that experience was a real wake-up call that at any moment, you could be zeroed out. Congress giveth and they may taketh away. So I think that was an important lesson. The other then, conversely, is, what's that Winston Churchill said, never let a good crisis go to waste. I may be misquoting him. But essentially, and unfortunately, fear is a good motivator. And so for years, as you and I and Lisa Simpson at Academy Health, the CEO, had been really calling on the community to do more, say more, reach out, contact your lawmakers, tell them why this is important, and people kind of don't because they have day jobs and they have other things to worry about. It was this moment where they said, oh, okay, so you were right. We should have been doing this all along. And now's the time to act. And I think what was critical to saving the agency, and I appreciate your kudos, boys, but really advocacy is a team sport. I might have been the quarterback, but there were a lot of people that made that save happen. And it was really people who were influential voices coming forward where they had not before. Where maybe, funding for health services discharge and funding for AHRQ was maybe in the top 10 of their priorities for advocacy. The clear and present danger from that appropriations bill elevated it to the top of the list. And so we had really key voices from the provider community, influential people in the health policy community, calling lawmakers, calling staff and saying, what are you doing? We were able to not just use sort of direct contacts, but also leveraging the media, using op-eds, again, from influential voices, social media, and sort of hammering lawmakers on their social media feeds. I mean, really just flooding the zone with outcry and outrage. We were able to nip that in the bud and turn it around. But it speaks to, ideally, you would take, as in public health, a prevention model. So instead of responding to the pandemic, hopefully we're preventing the pandemic from happening in the first place. That's really how I think about advocacy. It's all about prevention and hopefully avoiding those crises so we don't have to leap into action to save ourselves from the abyss. That makes sense.
It brings back bad memories. I mean, of course, The good thing is we are, and I should let staff know, we are in much better stead right now, and we are growing, and people really understand the agency, and our trajectory is very much in the positive direction. So I don't want to everybody out.
We're in a much better place.
We are in a much better place.
But I think, boys, we did not come out unscathed. I mean, the compromise there was, instead of zero funding, the agency is going to get a significant cut, and that was the compromise. And we, I say we still, AHRQ, in the community, continue to try to build back from that, and it's taken years. So yeah, we're in a much better place. But had, as the community, we've been more vigilant in connecting with lawmakers and telling the story and the value, we might have been in an even better place than we are now. So again, it's why it's so important. So
when you talked about, talking to stakeholders, talking to members of Congress, like what do you see the difference between talking to a stakeholder versus a member of Congress? And then the other thing that was very interesting that you highlighted is the power of congressional staff. And maybe you can explain how that works, because I don't think a lot of people understand how the role that staff play and the role that, in this case, appropriations play in this whole process. So.
It's a great question. Yeah. So, and I would say even within congressional staff, there's a hierarchy, right? And so as we think about communicating with policymakers writ large, and I would say, I put the executive branch in that category of policymakers. There are differing depths of knowledge, and I don't want to say sophistication, but kind of, in terms of subject matter expertise. There are definitely folks who are more sophisticated than others. And so I would say, as with members of Congress, and there's a hierarchy based on your tenure and on what committee leadership positions you have and what committees you sit. The same is true for staff who support the members of Congress. And within the staff, I would say committee staff generally have, because they have potentially a somewhat narrower portfolio, they're only working to support the issues of that committee's jurisdiction. They tend to be a little bit more senior in terms of their time in the workforce. They tend to have advanced degrees. They've been around a lot longer. They just, I think, are more open to scientific evidence, and they understand it better than, a congressional staffer who's just out of college working in a personal office for a member who may or may not be on a committee of health. And health is probably one of the only things their only thing that they're covering. They're covering education, they're covering transportation, they're covering veterans issues, so they are really more like the member of Congress, a mile wide and an inch deep, whereas committee staff tend to be a mile deep. But even then, I would just say, and having spoken with researchers a lot for many, many years, I'm talking about how to translate evidence to policymakers. I think the first thing to recognize, and this is a hard truth, is that science and evidence, if you're lucky, are part of the decision-making process and the policy-making process. They are never the only part. If you're lucky, they're a part at all. There are just a lot of motivators for lawmakers on where they land on given issues and how they make policy. And so I think for congressional staff, they are very attuned to their lawmaker and what their lawmakers' motivations are. And so even as they're intaking evidence, hopefully, they're filtering that through the lens of their lawmaker and understanding, what they're interested in, what their beliefs are, their core values, but also the broader political environment and what can work and what just can't. And there are some issues where there's just overwhelming evidence, and even there's overwhelming public support, but it's just never going to happen, right? Or it's going to take some time to make it happen. So that kind of all goes into the equation. The other thing too, I think, and I have to give credit to my friend and former colleague, Kristen Rosengren at Academy Health, who runs the communications an advocacy function there. We used to give a talk on translating evidence for policymakers and communicating with policymakers, and we came up with something we call flip the abstract. So it really is, I think, where in a journal article or research article, it's a build, right? You start with your background, you spend a lot of time talking about your methods, you eventually get to the findings, and then you at the end, the conclusion, your recommendations, what do the findings mean? Sort of how is this relevant? Why do people need to care? And there's usually more research is needed in there, but that's really kind of the so what. And I think for policymakers, you have to flip that. You've got to start with the so what. Maybe a little bit on the background, a little bit on the findings to support the so what, and don't even bother talking about your methods or your data sources, or that it's not that these folks are not reading journals, they're not reading MMWR. They might even probably not know what MMWR is. And they, unfortunately, for many lawmakers, they think in terms of tweets. So you have to really be able to distill and break it down to, what is that compelling title of the research article, which hopefully gives a hint about what the findings are and what you want lawmakers to do about it. But you really need to flip that and lead with that. And then finally, I know this is a long response, as I talk about evidence is part of what goes into decision making. It is not the only part, and what really carries a lot of weight, and I think it's hard for researchers to wrap their heads around this because it's been beat into you that the anecdote is not helpful, it's not generalizable, it's not worth it. The opposite is true for policymakers. They think in terms of stories, and it really is that personal story that helps motivate or can help provide context to scientific evidence. So there is a reason in the State of the Union address, as the president is building up to talk about a new initiative that they want to unveil, they point to the person in the gallery who is suffering from this ailment or had this wrong done to them to frame, this is why now I'm recommending we do this. That is how they think, it's how they react. And so the more stories, the better. And so what we would always try to do is we were talking about the importance of health services research and why it matters in those key findings. We would always be trying to think about, who is that patient or who is that provider voice that can come forward and say, hey, AHRQ put out this really good science. Here's how I used it in my practice of medicine, and this is the effect it had on my patient. Or I had this horrible adverse event with my patient, and if I just had more research or better evidence sooner, this would have helped prevent that from happening, right? So you've just, for a scientist to think in terms of the individual, that N of one is sort of counter to everything you believe. But when you're talking to policymakers, and I would even say journalists and the media, which is another important stakeholder and audience to reach policymakers, it's all about that personal connection and that personal story.
Yeah, that's great. At one point, we had a director who was in a hearing before the House Appropriations Committee. And the chairman of the Appropriations Committee said, what do you do with your research after it's finished? And he said, well, what we would like to do is get it published in journals and, medical journals and, the professional journals. We're hoping that, the academic community picks up on that. And then the chairman looked back at him and said, well, how does that help my constituents? How does that help, people in this case of Illinois, in my state? And, that director at that time really fumbled on the answer. And it really, shined a light on this is what we really need to focus on, because the research is very much important, but it is getting to that next level and explaining to folks that, or policymakers, that this ultimately helped your constituents, but this is how it helps your constituents, because most are pretty parochial. They're representing a district of 500,000 people, and they hear from them sometimes in the grocery store. So you got to try to identify with that, and I think that's that's a key. And I think you hit right on that, Emily.
No, it's such a great point, Boyce. I mean, you said it better than me. And when we talk about what motivates lawmakers, you know, there's their political party, and there's their personal beliefs, their core value systems. But ultimately, most lawmakers want to keep their job once they're in, right? So they want to do what makes their constituents happy. And so if they don't see a direct line of sight from, you know, what they're funding to benefiting their constituents, that makes it harder. And it makes it especially hard if they're not hearing from their constituents that this is valuable, or they're not hearing from voices that they trust, even if they're not necessarily constituents. It's why that's so important. And that's really what, you know, advocacy and education and outreach is all about. It's making sure you're kind of top of mind, because you don't want to be out of sight, out of mind. And also to really connect back to, what does this mean for my constituents?
So when we talk about what's this mean to our constituents, it's really, and you've talked about telling the story. I mean, that's having a narrative, as we know, is just so important in anything we do, right? I think that it just really helps illustrate things. Do you have an example? I hate to put you on the spot here, of throughout your career, it doesn't necessarily have to be with AHRQ, of a story that really helped illustrate to a policymaker, and I guess in this case, like how evidence went into policy and how it perhaps helps, you know, a policymaker's constituents, or, you know, a hospital or whatever it may be?
Yeah, I actually have a lot of examples. I can share one recently for the American Heart Association. And this is what we do, right? We're a science-based organization. So we have lots of researchers, many of whom care about health services research and AHRQ. But we're also a patient organization and a consumer-facing organization. So we really kind of bridge both worlds. And what we're really good at is bringing forward that patient voice. And so I'll just share, you know, most recently, an issue that had been making a lot of headlines. You may have seen a lot of ads on TV around surprise medical billing, which is a practice by which people receive a bill for care they expected to be covered under their insurance, and surprise, it wasn't. This actually happened to me, which was so funny. So to share my own personal story of labor and delivery, I was, and you know, Boyce, when I was pregnant for the first time and went into my baby and, gotta do the epidural, fine, at home recovering, doing well. And then I get a bill for my anesthesia. Like, what? Why am I getting this bill? I was in network, hospital's in network, my OB's in network. Well, the anesthesiologist wasn't not. Not like I could check in the labor and delivery room if my anesthesiologist was in network. But I received a bill for $7,000. And I was able to fight and get it covered and get it worked out. But a lot of people aren't. And so what we were able to do and really stall the legislation installed on Capitol Hill was to bring forward these horror stories of, we had a social media campaign, #IWasBilled, and it was just people sharing their story. Like, I had a stroke and I was airlifted by air ambulance and I was recovering, and surprise, I got a bill for $32,000 for the air ambulance. Like, I was unconscious. I was having a stroke. I couldn't check and see if the air ambulance transport was in network, right? So it's just bringing forward that story of like, and you, Congress, you need to fix this. You need to do something about this. And we were really able to break the logjam because we were able to bring forward all these patient voices of this egregious billing practice that I think everybody can agree is unfair and outrageous. To really motivate lawmakers in the face of pretty significant, I'd say, industry backlash, or trying to water down the protections, trying to stall the protections, we were able to break through. The other specific to health services research is someone probably everybody knows on this call, and that's Dr. Peter Pronovost. And I have to say, I think Dr. Pronovost was probably one of the most proficient communicators that I had seen, who could really connect with lawmakers and also make the research come alive and make it real, and telling the story of a young child patient that he had and how it motivated his research on quality, and how now, because of that research, the hospitals across the nation are now doing better. So he could really tell the full like panoply of like how this one individual patient and that experience led me to do this research, which then led to a change in how we practice medicine. I mean, it was so compelling and so resonated with lawmakers. And he also did it in a way which I think was important, where he said, and I did all this, I think I might quote him wrong, but it was not a lot of money. And he said, we did all this with a $500,000 grant. And like, now we're saving this much money because we're doing things a different way, in a more effective and higher quality way. And that, I think, for lawmakers were like, wow, oh my gosh, like you can have impact doing health services research. You could see the light bulb kind of go off as he's telling this story, and you see them just connect and be drawn in, which I think is probably one, if not the most effective example of storytelling about the value of health services research I've ever seen.
Yeah, and of course it goes with staying away from the jargon, right? Staying away from the stuff that we're all used to hearing. I think we sometimes a little bit too close to it. I had a director one time, we went up and met with the senator. And this is a while back when health informatics was a very big issue. And he talked about, he right off the bat, he said, so we want to really focus at the agency on health informatics. And the senator looked at him and said, health what? So it was one of these, moments where you got to realize that audience is not necessarily versed in this area. Not only they're not necessarily versed in this area, they are dealing with a million different things, right? And so, yeah, that's great.
Yeah, no, you're so right. And it's not just say that, lawmakers are ignorant or unknowledgeable. To your point, it's just, everybody I do not know a lot about foreign policy. So I kind of stay in my lane. I'm watching very closely what's happening in Ukraine, but I am not an expert by any means. I don't pretend to be. I think the same is true for lawmakers. And like you said, they've got 1,000 things plus that they're tracking on any given day. And so, you can't expect them to know everything about everything. And so it really is a good point about don't make assumptions in either direction, because I've seen that backfire too, where a constituent may go into a meeting with a lawmaker and they talk them down and they're patronizing, and the lawmaker's like, oh, by the way, I have a PhD in mathematics and I actually know a lot about this subject. So when I talk to people, it's important to be able to, in some ways, be a chameleon and meet your audience, your intended audience, where they are. And for me, it involves a lot of research about the person, about their history and their background and what their interests are. But it's also very easy to just say at the beginning of the meeting, here's what I'm here to talk to you about today. How much do you know about this issue, right? And they will usually be pretty honest. I don't know anything about this. Okay, well then in your mind, okay, I gotta start at the beginning. So when I first talk about AHRQ, I say the Agency for Healthcare Research and Quality, or AHRQ, because don't even assume they know it's AHRQ. They might be like, what's ARC? Is this the AHRQ that supports people with developmental disabilities? Like, what are we talking about? But you also don't want to go in and waste a lot of time, especially, as an example with committee staff. I don't need to level set with committee staff. I've been meeting with them for years. They know me, they know the issue, they know the agency. I can just dive right in. We don't need to spend a lot of time on background and context setting and all that stuff. So you never want that old saying about assumptions. You make an ass out of you and me. You want to be prepared for anything and be able to adjust your message on the fly depending on where that person you're meeting with is.
That's great. And I know we're running against time now, but I wanted to ask you, and being that we're lucky enough to have you here today, looking in your crystal ball, what do you see happening on Capitol Hill moving forward? What could be you think the priorities moving forward here? And especially like today, which I don't know if many people know, that we're supposed to be getting our appropriations bill finally today. So hopefully, staff, we will be off the CR pretty soon. So
I know, I'm like checking my text message. Is there any text yet? Have we seen the text? So this is a great question. So I will say I stopped making predictions after the 2016 election. I'm pretty good at it. But I will say my predictions about this year are playing out. You know, it's hard to say there's been a worse time on Capitol Hill. And every time I say that, it gets worse. So I'll knock on wood as I say that. It's a really tough environment. I mean, I think anyone who is watching the news or on social media, it's pretty broken. I mean, there are glimmers of hope in moments where they get it together. But to your point about the appropriations bill, if we look at, you know, Article 1 of the Constitution, this is like Congress's job. This is all Congress is supposed to do, really, in the Constitution. It's appropriate funding. And it's not going so well. And we're now, you know, we're not going to have a government shutdown. I'll predict that right now. Will not happen. We might have another short-term continuing resolution, but you know, we're now what, 6 months into the fiscal year, boys, and we still don't have a bill.
Right.
And if we can't do the basic stuff, they can't do the basic stuff, it gets really hard. I think obviously everything hinges on the midterms. I don't think I'm speaking on a turn here that it does not look good for the Democrats. Anything can happen between now and November, but I think it's likely that the Congress is going to flip. And so what I think is, and we're seeing that kind of play out now. I think no Democratic lawmaker would say that out loud, but just the now sort of, we're feeling it this spring. I think especially just this week, this sort of frenzied, oh boy, this is our last shot to get some stuff done. And we're bumping up against campaign season. Primaries are starting soon. You know, there's a small window here. And unfortunately, it's just really hard to do things in election years. So I don't have a lot of hope for this year. I think it's possible they do a couple big things, maybe big-ish. Build back, whatever we're calling it now. It's not Build Back Better. I think it's what, Building America Back, or we're calling it. I forget. I think the new acronym is BBA, and I can't remember what goes on. But I think they'll do something there. We'll see maybe some drug pricing. Maybe we'll see some tax stuff maybe in there. Maybe an extension of the premium tax credits for the ACA. But in terms of health policy, it's a mess. Like, we got some real big issues. You know, re-enrollment for Medicaid is huge. As many as 15 million people could lose coverage this fall, whenever the public health emergency winds down. I do think there's some hope next year for some bipartisan things. I'm thinking about the telehealth flexibilities, which again, as I think we think about the role for AHRQ, and I know you're doing some work in this area. I mean, can we think of a more fascinating natural experiment than telehealth during the pandemic, and the experience there and the opportunity there? And so bringing forward some of those learnings and that evidence about what worked, what didn't work, and how can we continue, because we can't go back. I don't think we can go back. I don't think anyone wants to go back, but how do we move forward in a way that's equitable and is accessible and provides quality care to all patients? I think there's a real opportunity there. So I do see some glimmers of hope for bipartisanship, even in Republican Congress next year, but it's rough right now.
Yeah, and as we know, you know, and it's just the nature of where we are right now, where we've been, you know, with this partisanship, it's just going to get harder. You know, when we'll see what happens. But if you have a one party in the Congress and then one party in administration, you know, they're going to have to work things out, or we're going to have gridlock.
Right. Yeah, I do worry that we're returning. It just feels a lot like 2010 to me, which you and I lived through, boys, and the Budget Control Act in sequestration. I have long thought we're going to end up with Budget Control Act 2.0. You know, already the deficit hawks are rising like phoenixes from the ashes, and now we care about the debt again. And it feels a lot like it did then. So I'm very mindful of cuts are probably coming. And it again is why it's so important that we remain vigilant and just communicating the value and educating lawmakers about what the agency does. No pressure on you, no pressure on Academy Health and the community, but just being present and being in front of lawmakers and talking about why this is important is going to be really important as the purse strings begin to tighten.
Right, right. Emily, we're talking about with folks here. Is there any resources you would recommend or anything like that for AHRQ staff to take a deeper dive to learn more about this area?
A great question, boys. So I would say the best resource and the most easily accessible resource is probably you, your team. I mean, you're very fortunate that you have Boyce and Jamie and others who it is their day job to talk to lawmakers and communicate to lawmakers and to be plugged in and to be watching and learning and having those receptors out to say, okay, this is top of mind for lawmakers. This will be really compelling for this lawmaker or that lawmaker. Y'all are probably the best resource for staff who, think, hey, I funded some pretty cool research, or I've done some pretty cool research, and just putting this on you, boys. Call Boyce and say, hey, this feels like it could be a thing. It could be relevant. What do you think? And how can we get this information out? So you guys are the best resource. I think another great resource for individuals who care and, want to help is your professional societies. So of course, I'll give a shameless plug for my friends at Academy Health. Professional societies, many of them are located in Washington, D.C. for a reason. And it's not because the rent is cheap. It's because of the proximity to lawmakers, and advocacy is a key function of a professional society. So if they're out there, boots on the ground, doing this work on behalf of the community, but they also are just great in terms of offering webinars and trainings on not just what is going on Capitol Hill, but how to do this stuff. And they have those resources available. So I think, to me, those are the top two. And then I will just say, if you're not on social media, if you ever want to know why is a lawmaker doing this, just check out their Facebook page or check out their Twitter feed. It's a scary place, but it sheds a lot of light on where they're getting their feedback from and what they're hearing, not always from their constituents, but what they're hearing. And it's a great window into what it's like to be an elected official, but also kind of what they're hearing and what they're feeling. And unfortunately, too often it's the vocal minority, and they're very vocal and they're very negative. And so part of our strategy that we employed at Academy Health or with my other clients while I was a lobbyist in a firm or now at American Heart Association is, and I'm a parent of toddlers, just rewarding good behavior, thanking lawmakers. They get spanked all the time for not doing enough, doing the wrong thing. They so rarely hear thank you. So just a simple thank you, and thank you for voting for that bill. Thank you for supporting our issue. That goes such a long way, and it goes noticed, and they will say, oh my God, I'm never thanked. So thank you for thanking me. And again, that positive reinforcement is really important.
Yeah, and I'd like to just emphasize the one point you made about the partner organizations, our stakeholders, is time. I think folks don't realize that, if there's one thing for an agency to be going up to Capitol Hill and saying how great our work is, but is a much perhaps more powerful when a partner organization conveys that message. They have a lot of members. A lot of these members of Congress and staff as well can identify perhaps more with that organization than a federal agency. So I think
exactly. And that was, again, to go back to Save AHRQ, that was key. It was the American Medical Association. It was the Federation of American Hospitals, the American Hospital Association, who, by the way, all have active political PACs that make political contributions, but going up and saying, what are you doing? Like, you can't do this. This is crazy. I mean, it was those unusual suspects and those powerful voices coming forward that really helped save the day.
That's great.
I'm gonna jump in right now. You guys this has been such an incredible conversation. Honestly, I think really valuable for the folks at AHRQ to hear, especially as some of the stuff we talk about, and I would say the Office of Director a lot, but a lot of our colleagues don't always hear the full story and really why we are so not careful, but like strategic about how we are talking about our work and how important that is. And obviously as an agency that has, we work we're very small. And so for us to be impactful, it's really working with our partner organizations and key stakeholders and how really important communicating our work and thinking about how we're communicating it is so important. So thank you for addressing that. We are super lucky. I have a couple questions in the chat here. One was, how can AHRQ staff reach out, to stakeholders if they have ideas, or to members? What should they do? And really, I guess this is kind of a question for Boyce, but Emily can react too. And what would be the process for thinking about that? If they have like a really good idea, what should they do?
That's a great question. And I would say you leave it to the professionals. So if it were me, and I was a staff member of AHRQ with really interesting research, my first call would be Boyce. Boyce that would then probably also loop in the communications team to talk about media. How do we get this in Politico Pro? I say it is really, I don't want to ever suggest people shouldn't contact their members of Congress. You have a First Amendment right to do so. But things can go off the rails pretty easily if you don't fully know what you're doing. So I say, first and foremost, call your professionals, call Boyce, and have a conversation and what he thinks. And so really you're communicating with lawmakers, but it's not direct connect. It's really through the eyes of a professional who's been doing this for many years, who can help frame that and really think through what is the strategy and who would be a good recipient of this information, and don't try to do that on your own. Again, because the likelihood of it going bad is probably higher than it going well. So if you're not, again, working with the professionals, it would be like me trying to perform surgery on myself watching a YouTube video. Like, I would go to a surgeon. I would leave it to the professionals. I would not try to do that myself, or I would not try to diagnose myself using WebMD. I would go to a professional. So I would think about it in the same way, because it is that important and you want to get it right.
Yeah, and I appreciate that, Emily. And that is, in an agency, any agency, what you also want to do, you want to keep that message centralized. Because you don't want all these different messages. And I've run in, because I've been at AHRQ for 25 years now, where I've had people freelance. And then what people also don't realize is that when you've been doing this so long, you do have the relationships on the Hill. So I had an appropriations staffer call me and say, why is this person from your agency calling me and asking me about their budget and why they didn't get X amount in their budget? That's not a good thing. So you really do want to have a centralized, consistent message. The right hand knows what the left hand's doing. And
exactly. Well, and this goes both ways. I'm reflecting on an experience of a staffer AHRQ that we had talked about, but you may have relationships with lawmakers, and that's great. And if you haven't told Boyce about it, you should. You may be friends with them. Your kids may play soccer together on a soccer team. Share that information with your team. And they can help think through, okay, well, let's talk about how we might be able to leverage that. And
to be clear, we don't lobby, but we are allowed to educate others about that.
Absolutely.
Oh, absolutely. Yep. 100%. And that's the other important point too, Jamie, is that your professionals, they know where that line is and they know how to stay within the bounds. And that's really, really important as well. I will just say this is not unique to a federal agency. I mean, the American Heart Association, on any given day, we have like 50 to 80 health policy priorities that we're working on. I have a team of 7 people, and they are, they're talking, committees of jurisdiction. They've got a lot of issues that they cover. And we have to coordinate. We're always sharing, hey, I'm having this meeting with this health staffer on ed and labor staffer who works on nutrition issues, because I know you're talking with them about nutrition, and we want to make sure we're all on the same page and nobody's caught off guard, because for people on the Hill, they don't see the different issue portfolios. They only see the American Heart Association. So if we don't look like we know what each other is doing and we're not coordinating, it looks really bad. And then you get the call from the staff, like, why are you talking about this? Someone else is talking to me about this. So coordination is key.
Yep.
And voice is the person.
Okay,
Sorry,
so we have
voice.
another question. So this is a good one, actually. In recent years, have you noticed any novel approaches to reaching policymakers? Is somebody using TikTok or something? Like, what have you seen?
That's a great question. Yes. So I think, and we have used a lot of these novel approaches. I think the days of, for us as an organization that lobbies, that traditional direct to connect lobbying of having a meeting and writing a letter, it doesn't get you anywhere. To break through, you have to be new and novel and loud, and you do that through media. And so I have a whole media advocacy team that really supports us in that way, both paid media, earned media. So paid media are like ads. Earned media is coverage in the Washington Post or op-eds or letters to the editor. So we're always thinking about that. And we are seeing in social media, particularly things like TikTok. It's interesting. I do think, though, it's important to be effective, to be authentic. And while it may be novel and creative, I think if AHRQ were to put out TikTok videos, people on the Hill be like,
Yeah.
why are you doing this? And I think for a federal agency in particular, you have to be really careful because you are stewards of taxpayer dollars. And so a perception that, like, why are you spending money on TikTok videos about your research? Shouldn't you be funding more research? Like, I think it can be risky. And so I would just say not being novel works, but it really depends on who you are as an entity and whether or not that means of communication is really authentic and makes sense for you as an organization. For the American Heart Association to do patient videos with TikTok, totally on brand. But for someone like the AHRQ, I don't know that I'd recommend it.
Yeah.
I don't know, boys, would you agree?
I would agree. Of course, I'll leave a lot of that to my communications folks. Howard Holland, I'm sure his head's spinning right now. But yeah,
I was like, don't do TikTok.
Because there's a fine line with the federal agency, and we are taxpayer funded, and we are stewards of the tax dollar, and you do have to be careful. In fact, years ago, we had a video of some directors on our website just talking about the agency, and a congressional staffer came after us for that. So yeah, very fine line.
Yep. Creative within limits.
Yes. Yes. And I would say, though, with today's mediums, communication mediums, and it expanding so much, I think that we can broaden that now. I think that the fine line's getting a lot broader.
Yeah. And again, I see a comment in the chat, I think the secretary doing a TikTok, okay, all right, we're trying to reach diverse audiences, especially if it's a campaign aimed at youth, like e-cigarettes or something, you want to meet people where they are, and the kids are on TikTok. So a Surgeon General on TikTok, yeah, okay, I can see that. Maybe not others. So it depends on who the messenger is, who the audience is, what's the message. I think that really influences, how you communicate.
Yep.
Yeah, no, absolutely. And obviously, I think I saw in the chat too that, we have guidance from HHS around what we can do, but we were just curious about what you've seen out there and what.
Yeah. Oh, definitely. We're seeing it everywhere. And, we're also seeing, and I can't even explain it, but I was hearing from some of my colleagues, some new stuff. I can share more offline if you're interested. Things that I had not heard of, and like, wait, what platform are we using now? This is how I know I'm aging, because I'm
This is a good example of of how partners can do things even in federal government.
Yeah, we did a really cool though. I'll just share around vaping and e-cigarettes. We did a really cool, very innovative, I think very innovative video, kind of YouTube. We went YouTube, TikTok, social media, with a poet, and it was like a slam poetry kind of. It was about menthol and targeting of the Black community and marketing, and you know, we got millions of views. I mean, so again, right message, right audience, right platform, you can really see impact. But you know, instead of, you know, your one pager or your here's what you need to know about menthol, to have this sort of, you know, poetry artist kind of talk about the impact of marketing in his community, in the Black community, was very, very powerful and actually, you know, really inspiring and attention grabbing.
Great.
So there's one other question. So it says NIH gets cures to patients too, but they do it within their individual institutes. How can and should AHRQ respond around getting cures to patients when the NIH does it too and with more dollars? So I think that's a question of like how we're different and how we differentiate ourselves a little bit, and what you're.
Yeah, it's such a good question. I mean, I think probably, Boyce, the bulk of our time together was working, trying to figure this out, right? Sort of fighting the argument of, well, isn't this duplicative? Or, I think two things, and where we landed in our messaging that I feel like was effective on Capitol Hill is, first, it's an and, not an or, right? So, health services research will never be biomedical research. And let's just admit that and own it. But what we do is we help propel the biomedical research into care delivery. And so really, if we're talking about reaching patients and we're getting the best outcomes for patients, we need to know best how to deliver these new innovations from NIH and the biomedical research community into practice. The second is, and where I think, and I believe this is a credible argument, and I think it resonated. When you think about NIH and the research they fund, yes, they are certainly funding translational research. They certainly fund health services research. But to quote, I have to give credit to Lisa Simpson at Academy Health, the CEO. Research from NIH is on diseases and body parts. It is very specific. It is not looking at systems. It is not looking at the patient, the whole patient as a system and what that means. And it's really doing research on how to make the health system. And so if you're thinking it from a disease body part versus systems approach, I think that's where AHRQ is very unique. And when we talk about, the waste, inappropriate care, excessive care, underutilization of care in our healthcare system and what that costs, we could clearly be doing better, and there are efficiencies to be found, and that's the work that AHRQ does and the work that AHRQ supports, is how to make our system function better and how to address the whole patient as a system, if that makes sense.
And that's a great way of putting it, Emily. And I'm
a little rusty.
Yeah, well, we used to always talk about, that the NIH's work was in a controlled setting. And I think it was Peter Pronovost, actually, we had a congressional staffer ask him, what do you mean by what a controlled setting versus what AHRQ does? He said, well, AHRQ is in the wilds of healthcare. And I thought that was a good way of putting it. So,
yeah, he's a brilliant communicator.
Yeah,
but that's true, right? It's where care happens. That's what we're talking about. Yeah.
So we are at the top of the hour. I just wanted to say a really big thank you to both Emily and Boyce for really having this really great conversation. It was really helpful, and I hope everyone, the AHRQ staff, enjoyed it. And for your colleagues who didn't get to see it, this will be posted on our website, and we'll be sharing that link as soon as it's available. Thank you very much, and have a great rest of your day, everybody.
Thank you.
Thank you all.
Boyce. Great.
Thank you, Emily, for joining us. It was a great conversation. Really.